them okay?
Yeah, as of now, we are fine. So till today morning, we had only less than, or maybe less than 5 patients. I mean, maximum, I think 6 we had.
Okay.
So, but we are getting prepared.
Are they locals?
Yeah, all of them are locals. I mean, because of the lockdown, people from other parts of the district cannot come to Vellore.
Oh, that's interesting. Okay.
So the government medical college Vellore, I heard, has more than 30 patients.
20. Okay.
30, yeah. And some of them are from the Delhi cluster, that meeting which they had in Delhi, and then they returned back, spread all over India. So that cluster, many of them are from that group, or contacts with that group.
Okay. And do they also have intensive care facilities?
Very
It should be 8 o'clock.
Yeah.
Okay.
Okay, so we will start. Jefferson?
Yes, sir.
Okay, so we will start.
Okay, sir.
Thank you, every one of you who joined this web meeting. And I'm privileged to introduce Dr. Johnson Samuel he has kindly agreed to share his experiences of managing hundreds of COVID patients in UK. Johnson Samuel is a senior respiratory consultant in Basildon University Hospital, and this is the hospital where Prince, Richa, Barney, and myself did our study leave for a couple of years, and he learned much from working in that hospital. So, and Dr. Johnson Samuel has been in the forefront of leading this war in that hospital, and which is the COVID designated hospitals. And as we in India, we are getting prepared to the war, it is good to learn from the experiences who are already in the midst of the battle, and shall I say, already partly won the war. So for the time being, we have muted everybody, and everybody's video is off. If you have any questions, please type it in the chat room, and we will take the questions at the end of the Zoom meeting. And in addition, if you have any other questions, we will allow you to, depending on the time available, we will allow you to unmute yourself and ask Dr. Johnson directly. If you have any connectivity issues, you can privately chat with the host, Pulmonary Medicine host, or Richu Bob Kurian host, and they will also share their WhatsApp number with if needed, so that you can sort out the connectivity issues in case you are using Zoom for the first time. So over to Dr. Johnson. Thank you very much for taking this effort.
Thank you, Bala. I can see DJ there as well. And colleagues, Barney, I just spoke to Richa a bit earlier. It's always good to share thoughts and our learning with CMC. And I was chatting to Bala called me a couple of days ago, and then he suggested that we have this Zoom meeting. And I hope this will be a bit of a sharing of experience more than anything else. So what I need to say right from the beginning, what I want to share is not going to be the basic science or going to tell you about the latest in treatment and such like. What I thought I'd just share is our experience managing COVID over the last, I would say, 6 weeks. So this is really our experience and the fact how we manage this, both in the structure, as in how does the management work, how it works as protocols, and how it works on the ground. So I thought it may be useful to put it that way. And also, I must say that this is not the official, document from any of our trusts. This is my observations. I thought I would share it and put it together so that it will be useful for this Zoom meeting. And I note that CMC has got a few webinars with OC Abraham chairing with I've just seen the topics, and they will have all the fine details about what is the latest and what's out there in the forefront. But I hope today's presentation will give us some idea of how to organize our services, how to be prepared, and so on. So that's the whole idea of this webinar. So I sort of put it across. Can you see my screen? The screen is visible, I presume, the slide screen.
Yes.
Yeah, excellent. So I sort of put it this way. So it's useful to, to have this management and leadership structure right at the top. So that's worthwhile mentioning, because that is absolutely crucial. Secondly, protocols are absolutely important, because when we started with like where you are now, and I'm hoping that you will not become like what we are. But we had very few patients to start off with, and we had a lot of leisure times, to put it that way, and things started escalating very rapidly. And because we put certain protocols in place, people could follow it. So I've just put down a few protocols there: staff protection, admission, cohorting, treatment, transfer, a bit on staff testing, and communicating with patients and carers. So I'm not going to go through all of that, but I'll just tell you the important things, and happy to share if people want to ask questions on the other bits as well. I must also mention that when we say protocols, we started with a certain number of protocols, and it is a significant learning experience. So many of our protocols have changed, sometimes on a day-to-day basis, depending on what the resources are and depending on what the patient cohort is and the intensity of the work. So a lot of our protocols do change. So that's something which we need to keep in mind. Then I thought I'd say a bit about training and redeployment of staff, which is quite important. Also a bit on equipment, and finally, how do we communicate, because everybody should sing from the same hymn sheet, and it's useful that we all do the same thing. So that is the sort of plan for what I'm going to cover. Obviously, I'm very happy to go into details of any of the things that people would ask. I'll just give you an overview, and I can send it to Bala, the presentation, if you want to disseminate. I'm very happy for you to do that. So as I said, the first thing which people have to put in place is a management and leadership structure. And when you talk about a leadership structure for CMC or the mission hospitals or wherever it may be one. It's important that you have one for the whole hospital, because if the pandemic hits like it's hit here, then it is not just the respiratory department. It will be every department who are going to be involved. So you need to have a trust structure. You will have to have a department structure as well. So, the Department of Respiratory Medicine, Department of Intensive Care will have to have its own structure and command and control. So the way it works for us in the trust, we have what's called as a command and control which is headed by our medical director. And we have a COVID lead for the trust. We also have 3 hospital sites. We used to be one big hospital called the Basildon University Hospital. As of the 1st of April, 3 hospitals have merged. And so we have a collective bed strength of close to 1,800, I think 1,900 almost, including the cardiothoracic center patients. So it's very important that this information is shared across. And we have a chief medical officer who is the equivalent of the medical director for all 3 trusts. And he coordinates it across the patch. And each trust has its own medical director, because each of these hospitals are 600 plus beds, have the medical director is a command and control. Then each of the key divisions, for example, emergency medicine, which is the front door where patients come in. You have respiratory medicine, which is another key department, and intensive care. So the 3 big departments have command and control people who communicate very, very frequently. So that's as far as the trust is concerned. And with CMC or with a big mission hospital, that is something which you will have to think about when you try and organize your services. Then each division as well will have its own, as I said, a group, and there will be a lead who will sort of coordinate, provided people don't fall off the cliff, as in become sick themselves. So it's important to have that structure in place. And the importance of this is, communication between departments and communication to the staff on the ground, both medical, nursing, and allied health. For example, we do have the trust command and control will send out WhatsApp messages. So all consultants in the trust are part of that group. To prevent people, replying, so only 2 or 3 people can actually send messages. So you can't reply to them, so you're not overloaded with messages. So we have that, and every day we receive a detail of the number of patients that we have, the number of ITU patients, the ones who are ventilated, the number of beds which are available in ITU, the number of beds which are available in the trust. And they also send things out giving us an idea of the number of patients discharged. Because quite often we can get quite depressed with seeing more and more patients coming in, but it's also good to see patients go out. Then the communication also has a bit of, staff numbers. So, for example, the divisions will each day they will the division of respiratory medicine. We know exactly how many registrars, consultants, and junior doctors are available, because people can fall sick, people can self-isolate for a number of reasons, and as the numbers increase, that is going to change, and therefore your rotas and your working hours change, and so people are and should be ready for redeployment. The other big thing about redeployment also is, we have in our trust and all across the UK, all elective work has stopped. So what does that mean? It means outpatients, we don't see any outpatients in clinics. Some specialties have telephone clinics or telephone consultations. Some even have video consultations. But that is only for people who need to be seen as follow-up. The new patients are not seen. No elective surgery is done except for urgent emergency surgery or trauma or cancer surgery. Nothing else is done. So that frees up a lot of staff, particularly in orthopedics, surgery, other specialties like neurology and dermatology, which are largely outpatient specialties in many trusts. So we have a lot of doctors who are available to be redeployed. So what we have actually tried to do is to redeploy the surgical specialties to the intensive care side. The junior doctors are redeployed, some to intensive care and some to the front end, emergency medicine. And then we use the general physicians. So at this point in time, we have 7 wards. which it was 5 till about a week ago. We have 7 wards, each of about almost 30 patients with COVID patients. So we soon realized that respiratory medicine can't manage them. And therefore, we redeployed our general medical consultants, as in other specialties like cardiology and renal medicine and gastroenterology. So that is something which is done on a regular basis. So that needs some training as well. And finally, we regularly review how many staff we need, simply because there are, as I said, people can become sick. And as of day before yesterday, I don't know today's figures, we had 320-ish staff who were sick with the COVID virus directly or indirectly. So that does cut down numbers. So we need to use other resources. And one of the resources we use is medical students. So CMC and other places shouldn't have a problem because you may have a lot of students on site. So the junior doctors start, or the first, here life starts in August. So the new batch of foundation trainees, so your interns, will start in August. But the General Medical Council has given them early registration, so they can actually start as of last week in different hospitals. So a number of these trainees who would have joined in August have actually started working as interim foundation year 1 doctors. So they are there and they are ready to go, and they are as good as our interns. Then there are year 5 and year 6 students who are year 4 and 5 and 6 who have volunteered, and they're being used initially as not patients facing, which means that they can do other admin stuff, they can do telephone calls, and they can do various other form filling and such like. But soon they may well be used for patient facing, because many of them can do bloods and blood gases and such like. So this is something which is reviewed on a daily basis. So who do we need and how much do we need? So this is absolutely crucial, having a good management and leadership structure. Then going on to, protocols. Protocols is something which you need to develop, and it all depends on what you are capable of doing and what you want to do. For example, there may be some hospitals like mission hospitals who will want to just transfer patients out. So you need to have a protocol to try and see who you'll transfer, who you'll keep. I'm just going to show you some of our protocols. And I thought I'll just start with admission as well. The general recommendation in the UK is we do not admit all patients to the hospital. Only sick patients come to the hospital, and the general recommendation is for everybody to self-isolate at home. They can call the national helpline, which is called a 111 line, and they'll be given advice. And they'll be given advice to go to hospital only if they're unwell, and in particular if they have breathing problems. So the numbers who come into the hospital are the ones who are sick. Having said that, there are people who come in who are not very unwell. So they are triaged. They only come through the emergency department, the accident and emergency department, ED. So they are first reviewed and with the proper precautions, which we'll come to in a minute. But the first thing we try and see is, do they need to get admitted? And the general rule of the thumb for admission is if they are in respiratory distress. And we have 2 big criteria. One, if your oxygen saturation is less than 94% on room air at rest, or you have increased work of breathing. For example, your respiratory rate is well above 25. So those are the sort of patients we would admit. If they are less than that, we give them what we call a safety net advice and send them home. And they can always come back if they become more breathless. There is this thing up there in front. You may be able to see it. But the ones we decide to admit, we then cohort them into 5 cohorts. There are only 4 cohorts shown. That there's an extra cohort which we've added recently. Interestingly, when we first started, they were called as COVID suspicious until the PCR results came back. In the UK, we only do nasopharyngeal swabs, and they are sent to different laboratories, and there's a lag period of up to 72 hours for the results to come back. So we initially cohorted them to thinking COVID suspicious wards and COVID positive wards. But we've stopped doing that because we know with the numbers coming in and with the clinical picture which has just emerged that we don't need to have this PCR test to make a diagnosis. So these patients have very classical type 1 respiratory failure, and they have a very classical X-ray feature. They have bilateral interstitial shadowing, very pretty much in the periphery of the lung fields. And when you do a blood test, they do have lymphopenia in about 60% of patients, and they also have a high and then they're cohorted. Obviously, the results will come back a few days later, and as you're aware, the PCR tests have got a sensitivity of about 65%. So it's not the best of tests. So once you see the patient, and some of these patients may not have classical X-ray features, and then we don't have classical X-ray features, but they do have what appears like type 1 respiratory failure. We get them to get a CT scan done. And the CT scan is also very classical, and it shows ground glass shadowing more in the peripheries, a fair amount of interstitial shadows as well. And many of these patients are young patients, so you don't expect that to be the case if it's not COVID disease. And then we cohort them into 5 groups. Cohort 5, I'll start with cohort 5, is what we call as the end-of-life care. So some of these patients come from nursing homes or come from care homes who got multiple comorbidities and are quite unwell. So they are actually sent to a cohort 5 ward, which is a palliative care ward, which is run by our palliative care physicians, and the family are informed. Cohort 4 is a group of patients, which I'll show you in a minute how we cohort them, who will not be for escalation other than for ward-based care. And that means they will not be intubated if they deteriorate. Is it all right for me to carry on? Or
Yes, sir. Yeah, carry on.
Yeah. Okay. So I just wanted to this. So cohort 4 is the patients who will not be intubated, and I'll show you in the next slide what they are. And we have certain criteria for them, which means they'll be ward-based care, and they can have CPAP or BiPAP in the wards, but they will not be intubated. And we do fill what's called as the DNA CPR form for them. That means do not resuscitate if they arrest, meaning cardiopulmonary resuscitation will not be done for them, and the ceiling of care will be ward-based care. That's cohort 4. Then we have cohort 3, which are patients who the ceiling of care will be all the way to full escalation, i.e. they will be intubated if necessary. And what the respiratory team has done is now take over 3 wards, which are cohort 3 wards. So we have almost, at any given point, 60 patients who will be cohort 3. And many of them are young patients who will be on fair amount of oxygen. And we'll talk about those devices in a minute as well. Cohort 2 are patients who are sort of borderline, but not requiring upwards of 4 liters oxygen, which means their FiO2 is not more than 40%. The requirement is not 40%. So we send them to a general medical ward, which have been managed by general medical teams. We expect them to stay in hospital for a day, maybe 2. And we also expect them to be moved to cohort 3 if they become unwell, to the respiratory wards. And cohort 1 is anything else, an asthma exacerbation, because in the old days, not old days, 4-5 weeks ago, we took a history of travel or contact with people of travel. The current thinking is anybody walking through the door is COVID unless proven otherwise. So we have had surgical patients with COVID positivity who have been operated and so on. So this thing about travel history and contact with travel, while it was useful in the beginning, we don't use it anymore. So that's what we do for cohorting, and we use X-ray, as I said, and CT scan in some patients. Before I come to that, just briefly mention this. What do we mean by treatment escalation? So there are 2 tools we use. One is a national tool, which takes into account a few things. One is the age, and we give some points for the age. And second thing, what's called as a frailty score, and going from very fit with a score of 1 to extremely unfit or terminally ill, which is a score of 9. And then you have comorbidities, including chronic conditions, recent admissions, hypertension, liver disease, and such like. So you add these things up, and if you have a score of less than 8, less than or equal to 8, then you can, they are full escalation. And if it's more than 8, they are really ward-based care. So that's how we go across. And we also have another tool which you use locally, which just sort of goes about the same thing. You calculate with the frailty score, and we decide whether to escalate or not. So this is very useful to cohort patients and to make sure whether they are 1, 2, and 3, or separate them from group 4 and group 5. So we use this, and how you adapt it to CMC, which will be something which you need to consider, but this is quite simple and can be used quite easily, because one of the things which drives this clearly is the ITU data. And as you're aware, the latest data which we've had as of yesterday from the Intensive Care Society audit suggests that your overall mortality for intubated patients is 52%, as compared to 28% 3 months ago, 22% 3 months ago. So there is a significantly increased mortality, and the mortality changes with age. So it's sort of proportional to the decade of the age, what we've observed. And if it's, for example, if you're 80-year-olds, you have a 20% chance of survival, and 20-year-olds got an 80% chance of survival. That's a sort of a ballpark number that we use, which is why the age comes into the corner in the number of points. The other thing which you have to decide as a hospital, as a department, as a division, is how or what are you going to use for your staff. So this is the latest version of the Public Health England protocol for what sort of PPE will you use, personal protection equipment. So as you know, you can have the simple face mask to an apron, to a full PPE, which includes the FFP3 masks and visors and gowns and so on and so forth. This is, as I said, this is a significant learning experience. The first version of this was very different from the version we have now. And I suspect some of it is to do with availability, and some of it is to do with availability of PPE, that is, and some of it is to do with what we are learning as we go along. And to sort of summarize that slide, you need to have full PPE in places where there is aerosol generating procedures done. For example, that will include the ITU, where patients are intubated. It'll include the respiratory wards, where we have a cohort 3 patients, where patients are on NIV, and the patients are on CPAP, or if they're having suctioning and such like. So those are the regions. And over the last week, we've extended to ED as well, emergency, accident and emergency, simply because a lot of activity goes on. For how far and how long the droplets and aerosols can remain. So that is a sort of protocol which you need to decide and you need to act. But the ballpark observation is that the respiratory wards will certainly need everybody to have this. This is very specifically for the respiratory, and I'm sure you're using non-invasive ventilation, both CPAP and BiPAP modes. The only difference is that they have to be non-vented masks, and all our masks otherwise are vented. You can't have an expiratory thing coming out. So you need to get very specific non-vented masks. And we normally use the filter, the bacterial filter, to go at the end where it gets into the machine. So you're really trying to protect the machine. But here you use the filter between the mask and the exhalation port. So the filter makes sure that whatever is exhaled comes out through the exhalation port, has some sort of protection from the virus. So that is the sort of connector where you have the bacterial filter instead of having it near the machine, and the masks are non-vented masks. That's absolutely crucial. This is a sort of a do's and don'ts in respiratory, which I've just sort of put things around, which is rather self-explanatory. Obviously, do not use vented masks. It has to be non-vented masks. Do not use OptiFlow. OptiFlow is the high flow humidified oxygen which goes across because there is aerosol generating procedures. We do not use nebulizers. And I put down that there is no need for a respiratory examination. We don't carry stethoscopes. I haven't examined the chest for the last couple of months. Because if you look at the patient with your observations and with your chest X-ray and your blood test, you're listening to the chest doesn't add anything more. We do use nasal cannulae, and we also have a large bore nasal cannula which we use quite frequently. We can give up to 12 liters through the large bore nasal cannulae. Initially, there was some worry about Venturi masks, and Bala, you'll recollect that I was suggesting that not using Venturi masks, but there's some evidence suggesting that the distance is not as different for any of the exhaled particles to come across. So we do use Venturi masks now. Because we don't use nebulizers, we use MDI with spacers in patients. We encourage patients to use a surgical mask in the COVID wards, particularly as we go and examine them so they can be coughing around the place. So at least to stop the droplets, we encourage them to use surgical mask. And we try as best to be about 2 meters away from the patient, which is rather useful. So these are just practical tips, and we just sort of modulated them as we went along. Right, we have discharge guidelines, and what does that mean? This is very difficult for you to look at it, but very simply it says that we try and wean people off oxygen from the wards as soon as we can. And if we have I said we admit patients with with the saturation of less than 94. The target saturation for patients who are cohort 3, which means fit young patients who are in type 1 respiratory failure, we try and maintain a saturation of more than 92%. So we don't aim for 98 and 96%, we aim for 92%. And we wean the oxygen as soon as we can to around 90, and they are stable on 92% for 12 hours, 6 to 12 hours, we discharge them. Because we don't want them to stay in hospital and get secondary infections. So there are a few other things like mobility and such like, which you can say. I think the other thing is staff testing, and I was just talking to some of you earlier. In the UK, we don't check the general population, so therefore we don't really know the prevalence in the community. We only test people who come into hospitals, and testing for healthcare workers and their households are also done. The recommendation in the UK is if you have a symptom, as in the healthcare worker has a symptom, then they have to self-isolate for a week. And so if you have the symptom and if you are positive for the test, you return to work at day 8 if symptoms settle. Otherwise, 48 hours following resolution of fever. If a family member has a symptom, which is fever, cough, or whatever it may be, we initially started off by isolating the staff members for 2 weeks, but we found that a lot of people were falling off the cliff, and therefore we started testing the family member for COVID. And obviously, if they are negative, then there's a 35% chance you may be wrong, but you still get the people to come back to work. So that's what we do now. I know that's not the practice in many parts of the world, and a lot of people are advocating more and more testing of the population. So this is what we do here, and I think it's a pragmatic approach. So those are the protocols. I've just given you some. We have lots more protocols. We have protocols of how to talk to patients, how to break bad news to patients, so which can be used by very junior staff and not by senior people. We have protocols of how, when patients are moved from primary care to their homes, how do you communicate with the GPs or to community hospitals. So lots and lots of protocols. But I've just put out the protocols which would be useful in India and which are probably the most important. The next thing I think we found useful, I must say that yes, we'll always be short of things, but compared to Italy and Spain, the UK was not caught off guard. There was some time to prepare because we are about 4 to 6 weeks behind them. And one of the things which people have done is tried their best, at least the UK has done, is tried to get prepared. And I think it cannot be emphasized how much you should be prepared, because you are probably many weeks behind us, and hopefully you'll remain that way. But if you don't, then preparation is absolutely important. I've sort of divided into a few things. The intensive care thing, support. Our equipment has increased substantially in ventilators. So to put in perspective, we have the main hospital which had 14 ITU beds, and our cardiothoracic center had 20 ITU beds, which is all on a side. So it's about 34. At the moment, we have close to 60 patients who are being ventilated, and we have capacity to ventilate another 60. So, and we are going to be the COVID hot hospital for the region. So that can go up to a further 50. So a total of 150 we can ventilate. So while you can get equipment, you also need people to train. People to operate the machines. And what we did was to use the ITU team to train general medical physicians, orthopedicians even, junior doctors, respiratory nurses, non-respiratory nurses, into the basic principles of how to handle a ventilator. And many places have got training modules. And I was talking to an ENT surgeon who said he never expected to be an intensivist, learning how to use a ventilator with a few PowerPoint slides. So, it's not rocket science. It can be learned, but it's useful to train them so that we don't have surprises. And it may end up that you may not have one-to-one nursing. You may well have one nurse looking after 3 to 4 ventilated patients, as long as there is adequate supervision. So we did train a lot of people, and we have about 80 people trained, and we can redeploy people from one ITU to the other and so on. So that's the ITU. The second thing is the respiratory HDU. It's useful for nurses to be able to handle NIV machines, CPAP machines, and how to monitor and how not to look. So that's the other thing we did. We also trained our general medical physicians. We trained our non-respiratory SPRs to try and help medical SPRs. The SPRs are registrars, your residents, who can come and handle non-invasive ventilation in the wards when they're on call. In the general COVID wards, as you know, most patients who are admitted are respiratory patients, respiratory problems. They are manned by GM, general medical physicians, and which is why the protocols are very important. They will know when to upgrade and when to downgrade and such like. So we made sure that they are aware. And as I said, we redeployed a lot of non-medical, as in surgical trainees and surgical consultants to other areas. A lot of the surgeons have gone down the intensive care route, while the non-medical, other registrars have gone to emergency medicine. And we employ medical students as well. And it's useful to actually teach them and tell them what's to be done. Equipment, ventilators, the big thing, and they are producing all kinds of ventilators. So far we haven't had patients which we couldn't ventilate, although we follow protocols, and some of the protocols are stricter than when it was before the COVID outbreak started. NIV machines and masks, as I said, non-vented masks, you still need that. You need a lot of it. Oxygen supply. Now, that is something which is very important and people don't think about. Each hospital has got its own oxygen supply, and that is meant to take a certain number of ventilators or a certain number of FiO2. And many of these patients require high flow oxygen. And therefore, your oxygen delivery has to be upgraded. For example, our hospital is having all sorts of pipes laid right now, so that the oxygen capacity is going to be significantly increased. Something which is very crucial, because you can't have many ventilators and not have enough oxygen. PPE, very obvious. which is something to keep in mind and keep a good stock of, and also to use it judiciously. So the idea of cohorting patients to different wards, when we first started, for example, we used to have COVID suspect patients in various wards in the side rooms, which meant that each ward had to have people to go in there with PPE and such like. And that was getting very difficult, with shortage of PPE. So once we started cohorting all the COVIDs into one place, it was very easy to do a ward round with one PPE and not change it between patients. And all we do is to change the aprons and the outer glove between patients if you actually touch them. I put oxygen concentrators there because it's something which I was talking to Sunil Gokavi and with the Mission Hospital. So if you're going to be, cylinders are going to be out of the question, because cylinders you'll run out of it in no time if you're going to give high flow oxygen. Oxygen concentrator is something which I think will be useful, and I'm told that it's available quite easily. And we can piggyback oxygen concentrators, even up to 3 of them, to get flow rate of up to 14-15 meters. So something to think about, something to be prepared for in places where you don't have enough oxygen, because the concentrators can use electricity and produce oxygen. This is absolutely important, as I said, communication across the hospital, all staff, because people should be aware, shouldn't be caught unawares. Specific clinical groups should need their own briefing. For example, every morning we have a respiratory and ITU meeting to let them know how many patients in our wards can potentially get to the ITU that day. And the other big thing is partnership, working with other hospitals and trusts and organizations. I put down the deaneries, because lots of here it all comes in. We are in the East of England region, and Cambridgeshire and Norwich and Essex is the East of England, and the training is coordinated by the deanery. So the deanery should be aware how we deploy our trainees and that they're looked after and such like. So good communication with them. The government is the General Medical Council, really, and Health Education England. One of the big things which has come out of this is adequate indemnity. So I'm sure India is no different from where we are. People can sue you for all sorts of things, but the GMC deaneries have given us, in many ways, a blanket rule to use our clinical judgment in the best interest of the patient. And especially because these are times which are unprecedented, and we may take decisions on the spot which can be questioned in retrospect, but if we take it in good faith, we have adequate indemnity. Something to think about in India as well. Communication with primary care or the hospitals or the homes that you're going to be discharging patients, and with the other bodies. For example, if we have regular meetings with I'm the director of medical education as well. So every week we have weekly meeting with all the DMEs in the region and the deanery, just passing information and saying this is what we've done, so that we are all singing from the same hymn sheet. And the Royal Colleges have been very useful as well. So that's pretty crucial. So I've gone through a few things, and this bit looked at training, protocols, management, equipment, and communication. So I thought I'd stop there. I've not mentioned specifically treatment, because as you know, lots of treatments are being advocated and the evidence is not hard. We have one study called the recovery trial going on, and we are part of the study. And we have 5 arms in the study. The first arm is a standard care arm. The second arm is using antivirals. There's lopinavir and ritonavir. The third arm is using interferon. The fourth arm is using dexamethasone 6 milligrams, and the fifth arm is hydroxychloroquine. So we've recruited almost 40 patients into it. It's a national study, and we should have the results pretty quickly. So as a rule, we don't treat anybody other than in the study protocol. We don't give them hydroxychloroquine, which I understand India is doing. I don't see a right or a wrong in it, but in the UK, we are governed by certain rules, so we don't treat outside of the research protocol. So I'm going to pause there. I'm happy to discuss anything more in detail. I thought I'll just give you an overview rather than go on and on about things. So please feel free.
Thank you, Dr. Johnson. It was very informative. Before I go to the, I think we have few questions in the chat room. If anybody else have the questions, please, can you please type in your questions in the chat room? And I will like to ask this question. Johnson, am I audible?
Yeah, I can hear you.
Okay. So you triage the patients based on chest X-ray, and if chest X-ray is normal, based on the CT scan. Is that right?
That's correct.
Okay. So there are two questions. So do you have a specific like CT scanning machine which is dedicated to the COVID patients, and because there is certain infection control measures in the CT scanning room itself. And another thing is, suppose if it is a bacterial pneumonia, and based on the or a non-COVID pneumonia actually, and based on the chest X-ray and CT scan, you think that it is COVID, and you put among the COVID patients, and finally it turns out that he does not have COVID, he will be already exposed to the COVID patients around, and then we are doing more harm to that patient than not. So what are your thoughts on that?
Okay. The first question is about CT scan. CT scan, the answer is yes. We do have in the hospital 3 CT scans rooms, and 2 of them are being used for COVID patients now. When it first started, it was only 1 which was being used, but now we're using 2. So that's the first question. The non-COVID CT scans, I must say, are only for target patients or for trauma patients now, or if they're coming with strokes, which need thrombolysis. So the others don't get urgency. The routine scans are cancelled. The second question is it bacterial or not? When we started, I agree with you, we debated this, which is why we kept them in side rooms and such like. But believe me, if you can do a ward round in my ward with all the patients, and the chest X-rays look almost identical. I've never seen this many interstitial shadows in my entire life, and they are all very, very classically in. This pattern is very, very unusual on the chest X-ray. That's the first thing. And if you do a CT scan, it's absolutely unusual in the mild patients. So the ones we do, see, if you come in with a desaturation with a reasonable chest X-ray, when you don't have any other reason, the dry cough and fever, it is absolutely classical. And if you do a blood test on these guys, the total WBC is not elevated. It's between 6 to 8. So it's in the normal range. And you find that the neutrophils are normal. And you find that there's lymphopenia. Lymphocytes are less than 1. And you have a CRP, which is usually in more than 100. So that's a very classical picture. And usually after, I didn't talk about antibiotics in these patients. I didn't talk about specific management. It's all oxygen, supportive care. And in week 2, we find some of that, if you do a blood test on them, you find that the WBC actually goes up and the neutrophils go up. And that's when they get the secondary infections. So we start them on antibiotics actually when they come in itself, not even on the second week, but we are quite careful about the second week. The reason we start them on antibiotics when they first come is most of them have had symptoms for at least a week by the time they get to us. They're not coming to us on day 1 when they had the dry cough. So that's why we start them on an antibiotic. So I can say that, when you have very few numbers, yes, you may want to, you want to be absolutely certain you want to put them in a side room. But once they start coming in over the last 3 weeks, in ED, the junior doctor looks at it and he or she will call us and on our COVID phone and tell us, this is it. We can see the X-ray remotely. And I can tell you the X-rays looks very, 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 very classical. Now, coming back to, can you have a lobar pneumonia? The answer is yes. we've had the lobar pneumonia-like picture. We had mild changes in the bottom of the lungs with pleural effusions in COVID patients. So it is putting the whole syndrome together. And I do understand that you will still get your pneumonias, you will still get the tuberculosis and patients like that. So that is where you need to put this syndrome picture together. You have type 1 respiratory failure with the interstitial changes, with the normalish WBC, with low lymphocytes, and not bringing up much phlegm is almost pathognomic. We don't even, as I said, we don't even examine the patients.
Okay, thank you so much. Prince has typed in a few questions. I'll ask Prince himself to ask those questions directly. Prince, you can unmute yourself and then ask those questions.
Hi, Prince.
Prince? Okay, looks like, okay, I'll ask on behalf of Prince. So one question which Prince has asked is, after CT, do we need to test with RT-PCR in the ward to confirm? If CT is classical, do we again test it with RT-PCR, the swabs?
We test everybody who is admitted.
Okay.
Okay, so the test is sent irrespective of what the CT shows. Now, the added question is, if the first test is negative, which can happen in 35% of patients, do we retest them? The answer is no.
Okay, thank you. So another question which Prince has asked is specific infection control in CT room. So if you have any documents regarding that, if you can send it to us, that will be of help. Or do you have offhand anything to suggest? Like in between patients, how much time should be there, or air exchanges or anything like that?
Okay, no air exchanges is a short answer. They are all, because as I said, now we are using two CT scans just for COVID, and they're almost certainly COVID, many of these patients. What we do is we do the usual precaution with them. The patients who go in there, they will have a PPE. I'll send you the actual protocol, but just to summarize, the patient itself will have the FFP3 mask when they go into the CT scan room. That's to prevent not just droplet or aerosol things coming from. All those staff there will be on full PPE.
Okay, thank you. So another discussion which has happened in the chat room is regarding the NIV non-vented mask. What is usually available in our NIV is single port, like the inhalation and the exhalation tube is the same thing, and there is a exhalation port there. So what you are suggesting is that there is a separate expiratory limb. Is it like, is that so the filter is attached to the separate expiratory limb? Is that right?
No. If you look at this is the mask. This is a non-vented mask. There will not be any fenestrations on the side. Okay.
Okay.
And there will not be any exhalation port here.
Okay.
Okay. So what happens is you have this is an exhalation port with an oxygen connector. Can you see that? This one. Can you see the slide on the next to the yellow, the third one?
Yeah. So where does that exhalation port fit in? I mean, where does it come in the circuit?
Okay. So this is the mask. The mask is connected to the filter.
Okay.
The filter is connected to the exhalation port.
Okay.
And the tube is connected here. Can you see this? This one is a complete port here.
Okay.
That's how it is done. So basically, the exhalation port is after the filter. When they breathe out, there's nothing coming out here. And this one, they come through the filter, and that's the exhalation port.
So can I ask a question?
Yeah.
Is it a single limb or a double limb, sir?
A single limb. There is a single limb.
So will there be rebreathing?
There is a chance of it having to to have rebreathing, but some masks will come with what's called as a one-way valve here as well.
Yes. Okay.
Some will have that. So, but I can tell you, it's not a problem. When you talk about rebreathing, because you have an exhalation port anyway, which is why the exhalation port is beyond the filter. That's all. So
No,
we're not
my concern was
on the mask itself.
Okay, sir. So my concern was these patients will be tachypneic, and they will be a higher chance of rebreathing. So that is my concern.
Okay. Something else we've observed is many of these patients are on CPAP. We put them on CPAP rather than BiPAP.
Like a COPD exacerbation.
Yeah, I haven't seen a COPD exacerbation for the last 4 weeks.
Oh, is it? Okay.
So I was just postulating that probably, social isolation and keeping the patients at home is more effective than smoking cessation in COPD patients.
Okay.
Because they're not coming in. It's interesting. Patients with COPD are not coming in. Patients with overdose are not coming in. Patients with strokes are not coming in as much. And the GI bleeders, a lot of them are not coming in because there's no interaction between people. So your chance of getting a secondary infection from whatever it may be is not there. And also people are scared to smoke because smoking is bad for your outcome, which is generally gone out as a good public health. So we use CPAP through this, and we normally have a blue shoulder which goes across like that. So we use it very well.
Okay, thank you. Barney asked few questions. Barney, you want to ask? Yeah.
Yeah, no. Samuel, you were talking about that we're not using nebulizers, which we've also decided for. But the practical problem we are having is when you have a patient who needs to be on NIV continuously, then is there a provision to give the MDI through the circuit, like how you can give on a invasive ventilator?
No.
So you need to remove the NIV and only then.
Yeah.
And what dose of MDI are you giving? Are you giving a higher dose than what you would give on the nebulizer? Or
No.
How are you equating it?
What we do is, see, as I said, many of our patients are type 1 respiratory patients. So really the problem in these patients is not bronchoconstriction. The problem is really in the gas diffusion side of things. So we haven't found a huge number of patients sitting there and wheezing. And you may remember all our asthmatics are semi-functional brittle asthmatics. Over the last 4 weeks, we saw one, brittle asthmatic coming in. So the problem in these patients is actually in the gas exchange. And many of them, obviously when you have lots of fluid, I suppose you're going to have a little bit of narrowing of blood of your bronchial small airways. But we haven't seen that nebulizer is making a bit difference in these chaps. Your PEEP itself is actually helping open many of these airways.
And I totally understand that, but the query is, so isn't COVID being the cause for COPD exacerbations? You've not seen that?
No, we are not saying. See, I would say that the number of COPD patients who come in through the door is about 5% of what we've seen before.
So in them, how are you giving in the COPD exacerbations? How are you?
We're giving them Ventolin and Atrovent MDI through the spacer. Ventolin we give 2 puffs up to every 4 hours. Atrovent we give them every 8 hours through the spacer.
So have you had anyone with type 2 COPD exacerbation, COVID positive?
We have at the moment a chap who is obesity hypoventilation. He's only 40. He's not grossly obese, but he's got he's on type 2 respiratory as well. He's on NIV as opposed to CPAP. That's what I'm saying. We haven't over the last 4 weeks done NIV for type 2 respiratory failure.
Okay, so.
But your question is valid. Through the circuit, no, you can't. So you will have to take them out and take it out. and do it. No, but can you give a nebulizer if you're on full PPE? The answer is you can. But you're good as long as you're wearing full PPE. You still can use a nebulizer if you want to use it. So it's not that you can't. You try and avoid it.
Right. Thank you.
So I have a doubt, like what about bronchoscopy for other indications? Like this, it is a malignancy, you are doing bronchoscopy for diagnosis, but patient can be a COVID carrier, asymptomatic carrier himself. So how do you deal with such a situation?
Every patient who has not just bronchoscopy, who is also having, believe it or not, upper GI endoscopy, they're wearing full PPE.
Okay, so all the staff are wearing full PPE.
Yeah.
And I saw in your email which you had sent, you told that all surgical aerosol generating procedures, you do a CT scan to rule out COVID. Is that right? Like tracheostomies and things like that.
Yeah. So if you're going to be, one, we are avoiding tracheostomies. Even in intensive care, as you know, the tracheostomy, you're only giving for patients when they are trying to wean down. And they're taking a longer time to wean rather than actually in the initial phase. So we are avoiding tracheostomy as much as possible is the first answer. The second thing is, we are doing CT scans, if you're going to be doing a procedure for non-urgent things, for example, if you're going to be doing a CABG, let's say you're doing a CABG or something like that, we ask for PCR anyway. And there is, I think I sent you the document on the surgical bits. They have, let me see if I got it here. They do a CT scan in these patients for.
Yeah, you had sent the email that you do a CT scan before the surgical.
That's right.
Aerosol generating procedures.
Yeah. So CT guided risk factor. What we do is all aerosol generating surgical procedures, we do a CT scan.
Okay.
Unless the test has already shown something.
Okay. So one of the questions in the chat room is, are your doctors who are symptomatic taking HCQ acithro course treatments?
No.
No. Okay.
It's not available. And there are some people who have taken, which, azithromycin, we have tended to give people azithromycin in week 2 if they needed it.
Okay. Next question is, do you reuse PPE masks? If how, do we disinfect it?
We don't, is the short answer. But can you disinfect? There is a nice paper which looking at how to disinfect things, which I have pulled it out. I can send it to you. So as I said, we use one PPE set for a whole ward round, and then we discard it. And what of that's okay because we leave the ward, but the nurses can go to the toilet and go out for lunch and whatever. So they keep their own gowns with their names pinned up. So they come back and use the same thing. But it's for the same patients. But we don't use it overnight for the next day or whatever. So but there is a paper which has looked at cleaning this thing. Obviously, it's not going to be the best. And as you know, the PPE, the seal is absolutely essential. I forgot to mention that we fit test everybody for FFP. I'm sure you'll be doing it as well. Fit testing is to see, is it the right fit, or can you do the aerosol? Can aerosols get in? And there's a test that we do for everybody to get it done. And unless you have the seal, particularly the nose, most of the seal goes. The short answer is, if we can get a new mask, it's always better.
Okay, thank you. Do you use any scoring systems like SOFA, PSI for stratification? Is the next question.
No.
Okay. Is there any difference in disease pattern among different ethnicity living in UK?
Good question. We don't have the answer as yet, because, but observations wise, most patients who have been ventilated are Caucasian. So that's one. If you look at the healthcare workers, most people who have died have been non-Caucasian. But there is another confounding factor there, which is obesity. Quite a few of we have, as of this evening, we have 19 healthcare workers, including doctors, nurses, who have died in the UK. So it's too early to say, is there a racial difference here? And the very fact that our experience, most patients are Caucasian, is simply because our population is mainly Caucasian.
Hi, sir. I have a question. Sujit here.
Yeah, go ahead.
Yeah, sir. Your patients who you said who didn't do too well, did they have travel history?
The travel history were our initial set of patients. Now, the entire cohort of the hospital now, I don't think anybody's got travel history. It's all endemic, as in acquired in the community.
Okay. Another question is
about the risk factors as well. The risk factors are, we are seeing more and more patients who going on to get ECMO, and are patients who are more on the obese side. And obviously, diabetes seems to be worse than hypertension in the scheme of things. And as you're aware, a lot of the patients who deteriorate and go down, the final route is really cardiovascular, because a lot of them go into cardiogenic shock. And a lot of the patients, even on day 6, 7, and 8, are ventilated on FiO2 something like 50-55%. So it is not difficult to ventilate them, but they do get cardiovascular comorbidities. It could be myocarditis, even cardiomyopathy, which they do get as we go along.
Okay, so another question is, negative pressure room, is it needed for bronchoscopy?
Good point. The short answer is, it'll be nice if we have it. Even if you look at MDRT and TB and that sort of thing, it'd be ideal to have negative pressure bronchoscopy rooms. When we first started, we used to put when we had only 1 patient or 2 patients, they were in the negative pressure rooms. If you're using full PPE and you're doing a deep clean, no.
How long are we to isolate a COVID patient who has recovered?
Okay, what we do, as I said, is all our healthcare people who come back to work 2 days after symptoms have gone. 7 days.
Okay.
Or 2 days after symptoms are
recovered. Okay.
Yeah. The cough can last up to 3-4 weeks.
Okay. So symptoms recovered means fever subsided for 48 hours.
Yeah.
Okay. DJ sir and Richa, you want any questions, DJ sir?
Hello.
Richa, go ahead.
Sir, many of the questions have been answered. Actually, my question was on this endoscopy only, which you asked basically. Should we really defer for the patients who are not urgent, that we have already decided? But the thing was this only, which you have already asked. We need full PPE cover before we plan to do.
We only do patients who are, as you know, you need to ask why you're doing the bronchoscopy. Sometimes, well, as you know, we do hemoptysis, normal CT, just to be certain. We don't do that anymore. Only if there's a bund or intra-bronchial tumor and they are target patients do we do. And we try and see a one-stop, as you know, if you can get anything by EBUS, we try and do that as well. Only target patients. Non-urgent, nothing. Bronchiectasis, just getting sampling, no. So we've cut down markedly. I think our list has gone.
No need. Yeah.
Okay, thank you. DJ sir, are you there? Okay, anybody else?
So I have one question, Barney.
Yeah, tell me. Go ahead, Barney.
I forgot the question.
Okay.
Not getting it right now.
Okay, that's fine. Okay, anybody else? Last minutes?
All right, I remember the question.
Okay.
So the early data from China tells that if you work in a like a ITU, NIV kind of setup with COVID patients for more than 10 hours, then there is a higher risk of contracting infection among healthcare workers. So what is the current shift strategy in UK, in Basildon? Have you changed anything? What's your take on that?
Okay, so ITU, they do 8 hours intensive care. Okay, the nurses do 8-hour shifts, and the consultants, I'm sure you know, out of our 7 full-time consultants, 3 are down with COVID. So we had 1 in 4. We're doing 1 in 4 respiratory on call, which means we do have one long day which starts 8 to 8 in the night, 12-hour shifts, and then the other 3 days would be regular 8 to 5 sort of shift. Now, the good thing for us is we are not always sitting in the ward.
Yeah.
So even on a respiratory COVID take, we have a general medical consultant who is full PPE in the ED, and he will look at the patients and cohort them, because now that we've trained everybody, they're able to do that. We only intervene in patients who are to be ventilated. So for ventilation, we have borderline cases. We have what's called as a 3 wise men. 3 wise men include 1 intensivist, the respiratory consultant, and the GM consultant. So we agree within ourselves to see which would be the best, whether a patient should be ventilated. There is always a borderline patient, which, you know, we have a score of 6 or 7, but if you look at them, they look terrible. And do you want to ventilate that group? So every ventilated patient, they'll speak to us. And we have a separate, there's an ITU regular team, and we have what's called as a merit team. You know what it stands for? It stands for medical emergency something. It's run by an ITU consultant, an ODP, and a nurse, and so these 3. So they are on ventilation on call. So the merit team, they are the ones who decide who come for ventilation, not the ITU has got their own staffing. So from the shift wise, 8 hours is the maximum that we do. People who are inside, as in sitting there. And I agree with you. The people who are most exposed are actually the nurses, because they are with the patients and sucking them and taking observations quite regularly and such like that.
I have one more question. In the A&E, do you have a separate COVID area and non-COVID area in the A&E?
We had, but it's completely COVID. It's all COVID now. The only area which is, well, that's wrong actually. We have, if it's non-COVID, for example, even if it's a stroke, they come to, you know, the old miners area. That is where the minor injuries, that's where it's non-COVID. So it's a very small area. And the hospital is like a fortress now. Nobody is allowed inside the hospital. No family with any patient. Nobody can come in. The only time one family member is allowed is if they're going to be put on, integrated care pathway, which means end of life pathway. So one person can come and see them. Otherwise, you're not allowed inside. So even A&E, just the patient is allowed, and then if it's a minor thing, the security they send them home. You can call the GP. And pediatrics is the other place which is clean. We have a separate area which is pediatric ED, which children can have their own bronchiolitis and whatnot. So,
by the way, have you had children with COVID positive children admitted?
We've had 1 child admitted. We've another lady who I had in my ward was 35 weeks pregnant. We didn't intubate, so she went to significant type 1 respiratory failure. So we decided we will do a cesarean section on the mother. So she did have spinal, but post-op she needed ventilation. She was in an ITU for 3 days. The child was positive. Child is fine. Mother and child gone home.
Thank you very much.
We don't interfere much with pediatric stuff. We just leave it alone. This just happened to be a mom who was admitted with me. So, yeah.
Okay. Dr. Christopher has sent a message that no questions, you have asked them all. Thank of the consultants. How do you encourage? So this will be my last question. How do you, don't you fear for your life? Don't you are afraid that you yourself will be down with COVID? How do you motivate yourself at the end of the day when you go back home and the next day when you come back to work, knowing that you are putting your life at risk?
Okay, two things to say, or three things to say really. Firstly, this is an unprecedented situation. So nobody predicted this, and we are all in the thick of it. The first and foremost thing as consultants, as senior doctors, your job is to motivate and encourage. Okay? And you really have to lead by example, and we've seen it. And I can tell you the people have just stepped up beautifully. So that's the first thing to say. The second thing to say is people are scared, and they are they're quite anxious and scared. So again, there are lots and lots of rumors floating around about lots and lots of things, and WhatsApp is not helping either. So your job really is then to actually be there with, which is why all these protocols are very, very useful. The guidelines are very, very useful. So we are all singing from, which reassures the staff. I didn't talk about reassuring patients because elderly patients, as you know, who are cohort 4, particularly the not for research, they can be extremely depressed and sad and worried and anxious. One of the big things what we try and do is to actually tell them stories of, or tell them or show them numbers of patients who have gone home. Lots of patients are discharged. So this is not universally fatal. That's the first thing to say, because we discharge on an average of 5 patients from each of our chest wards every day. And the day first day I discharged, in fact, 12 patients from the ward. And some of them were on 15 liters rebreathing for a few days on CPAP. And if you look at their X-ray, it's pathetic, but they get better and they go home. So that is very useful to pass that message across. So we do have a certain slide set and say, this is a patient who went home. And we have a classic patient of one is a GP who is a diabetic, blood pressure, ischemic heart disease, COPD, 76, was ventilated for 2 days and we discharged home. So we put up this, with this permission, we say, we show people saying, yeah, this can go. So yes, people die, but lots of people go home as well. So it's very, as senior clinicians, your job is to actually encourage the others. What are the chances of you getting it? A very good chance. Now, if it was the beginning of the pandemic, I'll be self-isolating now for 14 days. Some of you know my colleague, Dr. Pannu, who was sitting now, shares an office with me. So the first 2 senior colleagues went down sort of 2 weeks ago. And 3 days ago, my other colleague, who shares an office with me, is down with COVID. So if it was the beginning of the pandemic, I would be isolating myself. But if I do isolate myself now, there's nobody to run the place. That's one. Or, Dr. Pittman who sits with me. So 3 of us share a room. So technically we should all be isolating, and which means the place will crash. So we know that we've been exposed for 4 to 6 weeks, and we're all, in some ways, I'm praying that I've been a subclinical case somewhere along the line. And we just plod along. And if you get the disease, in 80%, it's a mild disease. The 20% that we are seeing in hospital, which happens to be a big number. So yes, you can get the disease. I suppose I'll have to wait for about 10 more days, which is the incubation period, to be absolutely certain I've not been infected by my colleagues. So there's always a chance. I think you should be prepared, but to know that 80% of the patients get better is a very strong message to go out.
Okay, thank you so much, Johnson, for taking
There's one
this.
question which just came in the group.
I've just put my last slide there. Closing thoughts.
Okay.
I think it's important to say it's a whole new world. The world may not be the same, or the people may not behave the same even after this thing stops. Social distancing has made a big difference in people's attitudes to life. I think the second big thing we learned is partnership working with people who you never thought you'd work with. People on the front line are people like fire service people and ambulance crew who do such an amazing work. And the other big thing which has come out is people, junior doctors always moan about things, one thing or the other. This thing has changed their perspective. The people just stepped up, and the people who are in surgery who are ringing up and asking, where can I go? And about the European working time and all that, everything we've binned all that. There's no such thing as European working time anymore. We have a completely new rota, and nobody's complaining. The GMC, deaneries, everybody said do what's necessary. So partnership working, and people have stepped up, including junior doctors, and it's actually increased my faith in the medical profession. So you will see that. And finally, I think I am a Christian, as some of you are. Never underestimate the power of prayer. I think we go on a wing and a prayer, and we go in his name. So that's why we're not scared.
So there was one question in the chat, if I may read that. It's asking, you're seeing a lot of patients. Do you have had anyone having a reinfection?
No, not yet. When I say not yet, I haven't seen any. So I think it's too early because it hit us about 6 weeks ago.
Okay, thank you so much, Dr. Johnson. It was a pleasure learning from your experience, and we continue to pray and that we together, as you told, with partnership, with God's strength, we will overcome this pandemic. Thank you so much.
We will. Thank you. Thank you very much.
Bye-bye.
Take care.
Thank you, Dr. Samuel. Thank you.